I'd like to introduce our presenters who we are thrilled to have with us today. First, we have Chad Abrish, who will be presenting a national overview of elimination of mother-to-child transmission of HIV. Chad is the Executive Director of CityMatCH, a national organization of urban maternal and child health leaders. Chad has worked on the issue of perinatal HIV prevention for over a dozen years and is dedicated to the goal of elimination. Next, Jenny MacFarlane will provide a state perspective on perinatal HIV prevention from Texas. Jenny is the manager of the Texas Department of State Health Services, HIV, STD, TB, and viral hepatitis units testing and prevention interventions team. She has worked in public health, HIV and STDs, and hepatitis for over 26 years and has led perinatal HIV prevention efforts in Texas since 1997. Finally, Dr. Kathleen Brady will provide a city perspective from her work in Philadelphia. Dr. Brady is the medical director and medical epidemiologist for the Philadelphia Department of Public Health's AIDS Activities Coordinating Office. She is also a practicing infectious disease physician and a faculty member at the University of Pennsylvania Perelman School of Medicine. Now I will turn it over to Chad to get us started. Chad, if you press *7 to unmute your line.
I am here. Can you hear me okay?
Yes.
Great. Well, thank you. It's a privilege to be able to have this opportunity to speak with you today. I gave a very similar version of this talk to CDC's Perinatal HIV Stakeholders Group earlier this year. So I'm thankful to NASDAD to be able to share it with a larger health department audience today. As was mentioned, I worked directly on mother-to-child HIV transmission for several of my earlier years while I was at CityMatCH, and I continue to have a real passion for elimination. I consider it an honor to have helped facilitate that April 2008 CDC meeting that resulted in what I truly see as the landmark work of Steve Neschheim and Margaret Lampe and Alan and Lauren and others at CDC DHAP that created the elimination framework. We'll talk more about that in just a little bit. And from that work in those earlier years at CityMatCH, I have developed a deep and abiding desire, as I said, to see us get there, to get to this goal of elimination. So hence the title of my talk today, Within Reach, why we need to believe in and push for elimination now more than ever. Back in those earlier days of CityMatCH, Magda Peck and I used to ask our perinatal HIV prevention collaboratives this question: how strongly do you believe that we can eliminate the transmission of HIV from mom to baby in this country? 5 being strongly believe and 1 being strongly disbelieve. And we would have our collaborative teams line up against a wall in a human Likert. We'd say 1's on this end of the room, 5's on the other. And then we'd clean that human Likert into 5 neat columns and have each of the columns report out on why they were 3's or why they were 4's or so on. And while we had some optimists and some pessimists, generally we had a pretty respectable bell-shaped curve with lots of 3's right in the middle. Then in April of 2008, there was that landmark 3-day meeting that I mentioned just a moment ago, with a ton of highly qualified and highly intelligent consultants from diverse backgrounds. And ultimately a conclusion was reached by the group. And the conclusion was this: elimination of perinatal HIV transmission in the United States is possible and should be pursued. We had our definitive answer to the question about belief, and it resulted in definitive punctuation. We removed the question mark altogether and replaced it with a simple period, as in, we believe, period. It also resulted in a definitive publication, a framework for elimination of perinatal HIV transmission in the United States. And somehow now already 6 years have passed since that meeting, and it might be a good time to check in and ask how we're doing. How we're doing in terms of the numbers, how we're doing in terms of our national prevention infrastructure, and how we're doing in terms of our commitment to get to the goal. I said the title of my talk today was Within Reach, why we need to believe in and push for elimination now more than ever, let me give you 3 reasons why, and then we'll talk for a few minutes about each of them. Reason number 1, because we still have some ground to cover in terms of the numbers. Simply said, we're not there yet. Reason number 2, because our dedicated national prevention infrastructure has diminished significantly. And reason number 3, because elimination of mother-to-child transmission is a battle that is worth winning. Let's start with the numbers. And before we look at where we stand, or at least a current estimate of where we stand, let's remember our published elimination goal criteria. There are actually 2 criteria for the virtual elimination that were put forward in that article that I showed you. The first was less than 1 infection per 100,000 live births. The second was less than a 1% transmission rate among exposed infants. The article cites an approximate figure, which still works well enough today, for live births in the U.S. of 4.1 million, which means we need fewer than 41 infections to reach our elimination goal for incidence. The article also cites an estimated number of HIV-infected women who delivered infants each year of 8,700, which means we need fewer than 87 infections to reach our transmission rate goal. And so here's where we stand with our most recent data, which takes us through 2010. And to avoid data overload, I'm going to ask you to look just at that bottom total row first, the one that says total, and follow that across. Here we clearly see that we're not there yet. If you look in the 2010 column, we still need a reduction in incidence and rate of around 80%. That 2012 number that you see there, second from the far right, that needs to be 41 or under 41. And the 5.7% rate, that's the one that needs to be at 1.0 or less. So we have some significant ground to cover. Now, moving up 1 row, you can look at the number here for whites. And we see some pretty great numbers here that are right at the CDC goal. If this were our overall national picture, we would be in great shape. But as you can see, it is not the whole picture. When you look at the rest of the data going up into the upper 2 rows, you can see that we really here have a marked disparity. And I mean, what can you say about this really? This is just a national embarrassment here in health justice. We're talking about a 20% rate inequity or more. I mean, this isn't okay. And we can't just simply shrug it off. And I'll say this, if we were able to bring equity to this disparity among our nation's babies, that would truly be high-impact prevention. So, why do we need to believe in and push for elimination now more than ever? Reason number 1, because we're not there yet, and because inequities are rampant. Reason number 2 for why we need to believe in and push for elimination now more than ever, because our dedicated national prevention infrastructure has diminished significantly. We're dealing with some significant erosion. As we all know, there are 2 major sources of prevention for this important issue, Ryan White Part D and CDC DHAP. Together, these 2 investments by our federal government comprise the overwhelming majority of our elimination effort. And they've taken us a very long way towards the goal, and they should be celebrated. So if we had more time today, I would talk about the current state and future direction of both of these aspects. But as it is, and given time, we will focus specifically on CDC's Division of HIV/AIDS Prevention. And again, the historic significance of DHAP in the effort to first reduce and now eliminate the transmission of HIV from mother to child cannot be understated. Remember this early perinatal HIV prevention history. 1995, the United States Public Health Service published recommendations for HIV counseling and voluntary testing for pregnant women. Following this, CDC began conducting enhanced perinatal surveillance activities in 7 states to monitor the effects of the guidelines along with other prevention indicators. Then in 1999, the IOM publishes Reducing the Odds. Here's where we get the prevention cascade, which is really important work. Also in 1999, and here's what I really want to pinpoint, Congress appropriated $10 million per year for perinatal prevention. With these funds, CDC was able to stand up EPS, enhanced perinatal surveillance sites, in 24 states and local health departments, along with prevention programs in 16 health departments. And it established partnerships with 6 national organizations. Now, these numbers in dollars would shift and change slightly over the years, but the surveillance and prevention cadre that was created by that 1999 congressional appropriation would hang together, and they would do incredible work over the dozen years that followed. They would, led by this highly talented and dedicated CDC staff team, they would publish MMWRs and Dear Colleague letters, create model protocols, issue new clinical recommendations, change prenatal HIV testing policy in dozens of states, change prenatal HIV testing practice among countless providers, set a visionary goal of elimination, create a framework to get to that elimination. They would adapt a sentinel review methodology, and I'm running out of space and time, so I'll just simply say they did much, much more. Here's the bottom line. They kept moving, and they did not stop. Now, this has been true for DHAP, and as you know, it has also been true for Part D for years. And from their combined efforts, the estimated number of perinatal infections have fallen from an original estimate in 2000 that was between 280 and 370 to the more recent 2010 estimate of 212. Now, there's been some statistical changes in the way those estimates are calculated over the years, but we're still talking about a reduction on the order of 100 cases annually. And with the lifetime cost of treating an HIV-infected infant estimated at $270,000, and that's the more conservative of the two estimates, $400,000 actually might be more accurate. But those $270,000 number and preventing 100 cases annually, it's a lifetime expenditure of $27 million. That's incredible work, folks, right? Incredible prevention effort that's being saved there because of these factors. Here's a slightly more sophisticated downward trend line. And I say slightly because the available surveillance data doesn't really allow us to do this justice, but this is a least squares regression that was calculated by some of the staff at CityMatCH. And what they did was they used CDC published data from the most recent HIV surveillance report to get perinatal infection estimates from 2008, 9, and 10. And then they also reached back to include a fourth data point from that published range estimate in 2000. Then they projected this trend line. Here are the points of significance. And yes, again, we wish there were additional data points, and yes, the longer out that you project, the wider the confidence intervals. We get all of that. This isn't meant to be a super sophisticated statistical analysis. Instead, we're simply working with what we have to try to project the future and try to project a better future that's within our reach. So here's the points of significance. First, we are projected to achieve the incidence elimination goal of less than 41 transmissions in the year 2031. Second, we are projected to achieve the rate elimination goal of less than 87 in the year 2026. It's just 12 years from now. We can do 12 years. We could actually accelerate that gap, I believe. And finally, and this gets me perhaps most excited, reductions since the year 2000 have created a cohort of nearly 1,000 kids in number who are growing up without the virus coursing through their veins from birth. I mean, this is absolutely outstanding. And I will say thank you right now to Ryan White Part D, Thank you right now to CDC DHAP, and thank you also to the health departments that are on the line right now and that have participated in this important effort. So, after those dozen years, in 2012, CDC released PS 12-1201, their new high-impact approach to HIV prevention funding for health departments. It was a huge step forward, and it also rolled perinatal activities into the overall HIV prevention grants. Now, on the plus side for perinatal, 3 perinatal activities were included in PS 12-1201. You can see them on the screen right there. They're essentially test pregnant women, prevent perinatal transmissions, and conduct sentinel reviews. One potential minus was that health departments were not required to allocate funds to these activities. So the question becomes, how much have health departments chosen to allocate to perinatal? Well, in their 2013 funding survey, the National Alliance of State and Territorial AIDS Directors found that of all reported resources, so this is going to be federal dollars and state dollars, that just 1% of funds are allocated to mother-to-child prevention. Now, I will suggest 2 things on this webinar. Number 1, that number undervalues the significance of the opportunity that we have to win this battle for women and kids in our country. It undervalues that significance. And number 2, it's people like me who dropped the ball on this, not health departments, not CDC. We, national organizations dedicated to promoting the health of women, kids, and families, should have better understood the implications of PS 12-1201, and we should have been in your ear advocating for fund allocation to perinatal out of your budgets sooner. We didn't do that, and it was to the detriment of the population that is living with the virus. But we have an opportunity to correct it now, and that is what this webinar is about. I also want to add that in looking at the dollars and cents here, the picture isn't completely grim. After looking at this data, I contacted NASDAQ to learn more about exactly what does 1% mean. And they were able to provide me with some really good intel. So 1% of all funding sources, including, again, state and federal dollars, translates into $5.4 million. 32, as you can see, 32 health departments were allocating no funds. 11 health departments reported some fiscal allocation to perinatal, and 18 health departments just didn't respond to the survey. Now, we don't know which health departments these are. NASDAQ wouldn't reveal that to me. They just simply said, generally speaking, the jurisdictions reporting funding allocation to perinatal programs are high to mid-prevalence jurisdictions that span the U.S. So I think the points of summary here are these. First, a handful of health departments are allocating a nice amount to this effort. This issue hasn't completely fallen off the radar. Second, and most importantly, too many health departments are allocating 0 resources to perinatal prevention. Even a modest investment from a majority of these agencies would be hugely important. Let me say that again, because if there was one takeaway point from all of this, this is what I would want it to be. A modest investment from a majority of those 32 health agencies would be hugely important in our effort to get to elimination. Lastly, now that we've all seen the data on health department allocations for perinatal, we can make collective change happen nationally. We can improve this picture. We know elimination is a battle worth winning. We've had the definitive answer on that for some time now. I want to assert also that reason number 3 why we need to believe in and push for elimination now more than ever is because eliminating mother-to-child transmission is a battle that is worth winning. We know we can win it. We should win it, is my point on this. Let me close with what is hopefully a bit of an encouragement and inspiration for us to do what we've been doing, to keep moving and do not stop. To do that, I want to share a quote from one of my public health heroes, Bill Fahy. Bill Fahy is the former CDC director and also former chief of the smallpox eradication program. This guy is a total public health hero. You can see him getting pinned here by the president for his efforts. And he is and should be an inspiration to us as we reach towards the elimination of perinatal HIV transmission. Bill, in speaking about the smallpox eradication efforts, said this: "The high point was when I saw in my mind that this could happen. It seemed inevitable. Indeed, it always seemed to me that surprise was inappropriate because it indicated a lack of faith in the idea." He says that surprise was inappropriate because it indicated a lack of faith. I think it's funny that he mentions faith, since we've also been talking about faith all these years. We've just been labeling it as belief. And we've been framing it as a question, as in how strongly do you believe or disbelieve. Bill says that's not the right way to go about it. We shouldn't have a lack of faith in the idea at all. Certainly not when the goal is attainable. And we know that elimination is attainable. I think it's time for a new question. And the question is about determination. As in, how determined are we to get to elimination? 1 being not at all determined, and 5 being this little guy here, strongly determined. See, EMTCT is a battle that is worth winning. It is no longer necessary at this point in the disease for HIV to be a maternal inheritance. It remains so for an inequitable few of us. Not because the disease has trumped our science. The failure is instead in our collective determination. We are so close, but this close isn't close enough. Not for me, and I ask that it not be close enough for you either. Let elimination be our collective target. Even if your state or jurisdiction hasn't had a transmission in years, we know that given time and a lack of systems attention, they will pop up. They will. And they tend to pop up in spurts. Let's avoid that by producing a baseline level of funding and attention on prevention. Let's be strongly determined together, because this battle worth winning for the smallest among us. And this smallest of wins would be a huge victory in a decades-long battle against HIV. Thank you.
Thank you so much, Chad. Next we have Jenny MacFarlane from the Texas Department of State Health Services. So Jenny, you can press *7 to unmute yourself and go ahead. I also just want to give a quick reminder that if any of our listeners have a question during any of the presentations, you can type it into the chat box on the lower left-hand side of your screen. Jenny?
Good afternoon, everyone. Can you hear me?
Yes.
Great, thank you. And I want to thank NASDAD for this invitation to talk with you all about the Texas experience when it comes to reducing, preventing, and eliminating the mother-child transmission of HIV. I also want to thank the leadership that we have at the Department of State Health Services and the CDC for their encouragement and support for assisting us in maintaining this as a focus and a goal for our state. We are quite a large state with over 26 million persons, and also we have 5 EMA and PGAs. So we are a large state that receives Ryan White Part A, B, and the other funding, along with HIV prevention and STD prevention. I just want to give you an overview of what perinatal HIV transmissions look like in the state of Texas since we started tracking them in 1990. This graph shows the number of perinatal HIV cases in Texas from 1990 to 2012. In 1990, we had around 60 cases of perinatal HIV, and there's been a dramatic reduction in the number of perinatal cases in the past 2 decades. So we asked, well, what led to this decrease? As you see here, in 1994, the pediatric AIDS clinical trial demonstrated that AZT could reduce the risk of mother-to-child transmission from 25% to less than 8%. And then in 1995, the U.S. Public Services published recommendations for HIV counseling and voluntary testing for pregnant women, which included educating women on perinatal HIV prevention. In our state, in 1997, we look here, we adopted a law requiring the testing of pregnant women for HIV. It began as opt-out testing, and the woman did have the right to refuse. And through the years, there has been a gradual decline of perinatal transmissions, but we are not yet at elimination. So here we see what it looks like when it comes to the number of infants born to HIV-positive women in Texas. And this is a smaller snapshot between 1999 and 2012. We are a large state. We do have a large number of exposed infants each year, between about 400 to about 450. And as you see by the red line, we do see the number of infected infants declining. However, we are not at the hopeful less than 1%. In 2012, we see that we are at about 1.5% when it comes to perinatal transmission. We do see the increase of persons living with HIV, like I said earlier, around the state, which includes the number of childbearing age women. And with our Healthy ADAP program and a strong care services program, we hope to continue to strive for women to get into care, stay in care, and reach viral suppression. Here are our statistics when it comes to the year of birth, the number of pregnant women, the number of births, and the number of confirmed infected infants. But then we take a step further and we look at the percentage of exposed infants receiving the ideal 3 arms of therapy. And the 3 arms of therapy are to be when a woman receives antiretroviral therapy throughout her pregnancy, during labor and delivery, and for the infant to receive therapy at birth. Through tracking the information when it comes to what the successes are of women receiving 3 arms of therapy, we do identify the possible missed opportunities, which are very concerning. And through the years, with our partnership with our own surveillance program and our prevention program and our public health follow-up programs, we're able to look at the data through our chart reviews. In 2013, our data is still incomplete. However, we do suspect that we will continue to decrease the number of perinatal transmissions. Earlier, Chad talked about the CDC support for jurisdictions that started in 1999. And we are fortunate to be one of the jurisdictions that received this support for us to focus on reducing perinatal transmission, since we were a high prevalence state, or we are a high prevalence state. With the support from CDC, we looked at how we needed to focus training and guidance on perinatal HIV prevention to care providers, and also educating our providers on our state law. At the time, in 1997 until 2010, our state law required the testing of HIV, syphilis, and hepatitis B of pregnant women. Again, like I said earlier, opt-out at her first prenatal care visit and at labor and delivery. We identified the missed opportunity at labor and delivery when a woman would present and she would not receive her results until she was released. And again, those missed opportunities of not initiating antiretroviral therapy during LND, and also the baby going home breastfeeding and not receiving any type of therapy. So we focused on training and guidance when it came to the Texas law and how we could support the hospitals and labor and delivery sites to adopt expedited testing at labor and delivery. We also used our support in order to focus on specialized perinatal HIV case management to assure that women stayed in care when they knew their HIV status, and they received not only support to get to their HIV medical appointments, but also their prenatal medical appointments. And another key element of our activities was the community mobilization. Now, we didn't call it necessarily that at the time. We knew we had to affect the stakeholders out in the field, outside of our HIV/STD program, and get them to start talking about the reduction of perinatal transmission. We brought together partnerships of maternal child health, public health follow-up, Ryan White care service providers, our surveillance programs, and also our local ACOG. We built the Texas Consortium for Perinatal HIV Prevention, and since our largest number of perinatally exposed infants were occurring in Houston, we also focused on assisting Houston in a specialized task force. This brought us to a formal consortium that still exists today, and the focus has been to reduce or prevent the number of perinatal HIV transmissions in Texas through the efforts of perinatal HIV champions. Again, this is getting outside of the box of thinking just about HIV providers, talking to pediatricians, hospital administrators, obstetricians who may or may not see HIV-infected women, talking with federally qualified health centers. Again, reaching out to the non-traditional partners at the time to bring them to the table and help them understand the Texas law around routine testing of pregnant women, but also help them make changes to their systems and operations. This initiated more dialogue, this initiated greater collaboration, and also we had outcomes that we were pretty proud of. This stakeholder group brought together the big brains around the state when it comes to understanding infectious disease in pregnant women and exposed infants. They created a guideline for the care of HIV-infected pregnant women specific to Texas. Again, we train the stakeholders to do their own education for places like labor and delivery sites and building their best practices. And ultimately, we created an online webinar training course with CEs, which included CMEs and CNEs, when it comes to how to reduce perinatal transmission of HIV and also congenital syphilis. Sorry, I'm having a little bit of a problem with my computer and clicking the slides. There we go. So we go back to our law on testing pregnant women. Well, through this consortium, everybody was talking about, well, again, another missed opportunity occurred when the labor and delivery site did not get the results back timely to the provider. So this group came together and provided recommendations to policymakers on changing the law for testing pregnant women. In 2010, our law changed, and it is the Health and Safety Code 81.090. And the law states, again, to test for HIV, hepatitis B, and syphilis at the first prenatal care visit, and then in line with the 2006 recommendations to test for HIV during the 3rd trimester. The law went further to say, well, at labor and delivery, if there is no 3rd trimester test, you must test for HIV, and those results must be returned within 6 hours. The law went a step further after that. So if at birth of the infant and you can't find a 3rd trimester test, or you can't find, or there was not an L&D test of the mother, you must test the infant within 2 hours of birth, and those results again must be returned within 6 hours. Our law maintained the testing of hepatitis B and syphilis at labor and delivery. I can tell you right now, through all this discussion and collaboration, our stakeholders are now looking at educating policymakers on including 3rd trimester syphilis testing as well. We do still have a significant problem in our state when it comes to congenital syphilis. Now, the other thing to keep in mind, as a state health department, we do not truly have great big teeth when it comes to making providers adhere to the law. However, through the education of our stakeholders, we believe that peer support and that education of risk managers has been effective in making sure that policymakers and the administrators at sites understand what the laws are. We created fact sheets to distribute to providers and the general public. Mostly these go to providers on the laws and the requirements. We also created perinatal testing brochures. Now this is something that our law requires the state health department to do for us to create. And these are specific for pregnant women, and they talk about the reason why a woman is being tested for HIV, and also it includes syphilis as well, and it is in English and in Spanish. These brochures and handouts, fact sheets, can be ordered online for free from our Department of State Health Services materials warehouse. The other wonderful document that we created is this is a brochure. These are more like, not necessarily brochures, more like booklets. And it is for women living with HIV and helping them understand the importance of receiving ongoing medical care. And we created these brochures, and they are specific for women and also directed to African American women and Latina women, and they come from their stories. We went out and interviewed women who were living with HIV and had had a pregnancy. And we talked with them about what their experience was, and we created these stories for them. And these have been very popular, and we still receive positive feedback from women saying they really like reading this because it really talks to them. So this was all done right before the FOA came out. And as Chad said, that the CDC did include in Category A, Comprehensive Prevention for Positives, the bullets on addressing perinatal HIV prevention. Well, we saw this in the FOA, and we thought this is something that we still wanted to dedicate our resources to. So we continued with our stakeholder education, and that meant putting out into the field and supporting the education of stakeholders, performing what's called public health detailing, promoting the idea of providing the best care for HIV-positive childbearing age women and pregnant women, and marketing of best practices to clinicians, administrators, and stakeholders. The education that's been occurring is once again around the Texas law, also with the new diagnostic algorithm and the new test technologies. We've been reminding them of how they can, pretty much eliminate or reduce the number of indeterminate Western blots that they've experienced in the past. We also, again, kept coming up to understand that so many providers are not aware of the Texas Medication Program, Ryan White and state services that are out there, also about disease intervention and public health follow-up. And then, of course, the perinatal hotline as well, to make sure that providers understand that they are not alone and there is support out there for them. Another part of addressing the missed opportunities was building our partnership even stronger with surveillance, because we have been tracking whether or not the mom received the 3 arms of therapy. But also it came down to, well, wait a minute, what is happening when it comes to reporting rules and what is being reported? We took a step back and we actually firmed up our reporting rules for cases where an infant is exposed, and all the follow-up testing for that infant, including the negatives, were to be reported. So we had a stronger tracking of when we had a true negative case versus only being notified when we had positives. At the time, we were also able to firm up the Texas Train course that we created, that webinar. And also, it made us realize that through these, not being able to see through the chart reviews what the true missed opportunities were, what was the possibility of us establishing an HIV FEMR for us in our state? So we've been working for over a year now on establishing a FEMR HIV, and since the Houston area has the largest number of exposed infants in our state, we will be piloting this in the Houston area. This is a collaboration between the Texas Department of State Health Services, the Harris Health Systems, Baylor College of Medicine, CDC, and CityMatCH. We will be reviewing perinatal HIV and congenital syphilis cases. Now, this has been a bit challenging and tricky for us because DSHS does require we go through the IRB process, which we are still in the middle of doing. But through the support of CDC and CityMatCH, we are in all the other jurisdictions who are well experienced in doing this, we are receiving technical assistance and guidance from those programs so that we can establish our FEMR HIV. And one of the other points I want to make sure I highlight is that as we've been preparing for this FEMR, we've been educating our surveillance partners, our partners in public health follow-up, our partners out in the field, to let them know down the road we will be doing more in-depth review of the cases where we have an infected infant. We will be attempting to interview the mother to hear from her what were her experiences throughout her pregnancy, so that we can take those to a case review team, have them identify the missed opportunities, and then also taking that information from the case review team to a community action review, and then having that community action review provide recommendations and put into action what kind of changes have to happen in the systems, in the operations, so that those missed opportunities don't occur again. Well, I must give our acknowledgments to the staff members here. Casey Russell is our surveillance staff who pulls together, and she is excellent at communicating with us at the program level regarding what's happening when it comes to exposures and infections, but also our partners in the field, Dr. Levison and Margaret and Lauren, and our friends at CityMatCH. Thank you all.
Thank you, Jenny. Next, we have Kathleen Brady from the Philadelphia Department of Public Health. So Kathleen, if you want to press *7 to unmute yourself, and you can go ahead.
Okay, great. You can hear me, correct?
Yes.
Okay,
Thanks.
perfect. So good afternoon, everyone. First, I'd like to thank our colleagues at NASDAD for giving me the opportunity to present some data from Philadelphia today. All right. So Philadelphia has had perinatal HIV exposure reporting since 2005. And prior to that, it was conducted on a voluntary basis. We implemented name-based HIV reporting in 2005. But we obviously had AIDS reporting prior to that. We also implemented femur HIV methodology in 2010 and now have several, I guess we're in our 5th year now. We just started that. So, and we have found that these two processes are very complementary. And the issues and themes that have been identified through our femur HIV process have been able to be researched through our perinatal HIV exposure surveillance that is also being conducted. And so today I'm going to provide a brief overview of 3 analyses that the Philadelphia Department of Public Health has completed recently. So they're listed here. The cesarean section practices among HIV-infected women in Philadelphia between 2005 and 2013. The time of HIV diagnosis and prenatal care impact outcomes in pregnant women with HIV, and the HIV Care Continuum for postpartum women in Philadelphia from 2005 to 2011, and looking at barriers and facilitators to relinkage to care, retention in care, and viral suppression. So some brief background. There are currently 19,564 people living with HIV and AIDS in Philadelphia, and 1.3% of all Philadelphia residents are known to be living with HIV. On this slide, the number of perinatal HIV exposures between 2005 and 2013 can be seen over time. And for this particular, all our analyses in this presentation, a perinatal exposure is defined as an HIV-infected woman who delivered. So twins or triplets are only counted once. As you can see, there's been a decrease in the number of exposures over time, which is actually directly related to a decline in the number of women who are living with HIV and AIDS that are of childbearing age. So in our first studies have shown a significant relationship between mode of delivery and vertical HIV transmission. The risk of transmission is proportional to the concentration of virus in the maternal plasma, as well known, and current guidelines call for HIV-infected women with a viral load greater than 1,000 copies per ml or an unknown viral load near the time of delivery to have an elective C-section, or scheduled C-section, as the OBs, I think, prefer us to call it. No surgery is truly elective. A C-section performed before the onset of labor and rupture of membranes is most effective in reducing the risk of vertical HIV transmission among this population. However, compliance with these guidelines is really unknown. The objectives of this analysis were to determine the mode of delivery among HIV-infected women in Philadelphia and to determine maternal factors associated with performance of an elective C-section among HIV-infected women with a viral load greater than 1,000. The independent variables of interest are included on this slide. Demographic variables included age, race, ethnicity, nationality, marital status, health insurance type, HIV risk exposure category, and illicit drug use. Clinical variables of interest included HIV viral load at the time of delivery, antiretroviral prescription, the timing of antiretroviral use during pregnancy, and the Kesner Index. And for anyone who's unfamiliar, the Kesner Index is a validated measure of adequacy of prenatal care, which takes into account the month in which prenatal care began, gestational weeks at the time of delivery, and the number of prenatal care visits. The Kesner Index was classified as adequate, intermediate, and inadequate / no prenatal care. There were also 2 unknowns, which were included in the inadequate, no prenatal care category. So here we have the demographics of the study population that were included. Our cohort included 824 deliveries from 648 HIV-infected women, of whom 51.3% were between 25 to 34 years of age, 79.0% were Black, and 80.5% sexually acquired HIV. 39.1% of the entire cohort received adequate prenatal care, 38.3% received intermediate care, and 22.6% received either inadequate or no prenatal care. Most women had antiretroviral therapy prescribed at some point during their pregnancy at 85.3%. When ART was initiated for the first time, it was usually started during the first or second trimesters in nearly 2/3 of cases. The total number of prenatal visits varied from 0 to 30 with a mean of 10. And during the 8-year span, 16 out of 824 infants tested positive for HIV, which resulted in mother-to-child transmission rate of 1.9%. The results of the first objective are included here. Over a quarter of women had a viral load greater than 1,000 near the time of delivery. 61.0% had a viral load less than 1,000 copies, and 12% had an unknown viral load. On the left, you can see the mode of delivery for the 222 women who had an HIV viral load greater than 1,000 copies per ml. 48% had an elective C-section, 32% had a vaginal delivery, and 20% had an emergent C-section. In comparison, on the right side of the slide, out of the 503 women with an HIV viral load less than 1,000, 57% had a vaginal delivery, 30% had an elective C-section, and 13% had an emergent C-section. Women with an HIV viral load greater than 1,000 near the time of delivery were twice as likely to have received inadequate prenatal care as measured by the Kesner Index than women with an HIV viral load less than 1,000, and were less likely to have ART prescribed at any time during their pregnancy. And both of those were significant. Okay. So here we have the outcomes of the multivariate analysis of factors associated with an elective C-section among women with a viral load greater than 1,000. We included all demographic, behavioral, and clinical characteristics except for being U.S. born or not in a multivariate regression model. We evaluated factors associated with receipt of an elective C-section among women with a viral load greater than 1,000 only since the practice guidelines apply to that population. We found that race and having a previous C-section were significantly associated with having an elective C-section. Blacks were 80% likely to deliver via an elective C-section compared to whites, and women with a previous C-section were 32 times more likely to undergo an elective C-section. Age, origin of birth, marital status, insurance coverage, the HIV transmission risk, history of injection drug use, and the quality of prenatal care received, and gestational age were not associated with delivery via C-section. We also conducted a sub-analysis of women with a viral load greater than 1,000 copies by race. There were no racial differences in the HIV viral load, quality of prenatal care received, ART prescription, or timing of ART initiation during pregnancy, and that data is presented here. And of note, the mean week of gestation at delivery was 37 weeks among whites. And I guess I don't have the information for blacks on my slide, so I apologize for that. Okay, so only half of deliveries in HIV-infected women with a viral load greater than 1,000 received an elective C-section. Disparities in receiving elective C-section exist, with black women having significantly lower rates than white women. A substantial proportion of births, 20.1% to be exact, resulted in preterm deliveries or occurred via emergent C-section. That was 20% of women with a viral load had an emergent C-section. It's possible that some women either delivered before their scheduled C-section or that they developed obstetrical complications leading to an emergent C-section. And measures to reduce the risk of premature labor, such as abstinence from drugs and strong engagement in care, should be emphasized, particularly among women with an elevated viral load in the third trimester. Okay, I'm going to move on to our second analysis here. And here we utilize the same cohort that we utilized for the C-section analysis. And we wanted to determine the ART receipt and HIV suppression rates close to delivery among HIV-infected pregnant women. to evaluate how timing of HIV diagnosis and quality of prenatal care are associated with these outcomes. The demographic variables that we evaluated included race, ethnicity, health insurance type, substance abuse during pregnancy, and birth year. Clinical variables included adequacy of prenatal care measured via the Kesner Index, which I previously described, and timing of HIV diagnosis, either before pregnancy or during pregnancy. This slide shows the percentage of women who received ART in yellow and those who achieved viral suppression in blue based on whether they were diagnosed with HIV before pregnancy on the left and during pregnancy on the right. 89% of women diagnosed with HIV before pregnancy received ART, and 56% achieved viral suppression at delivery. In contrast, 71% of women diagnosed with HIV during pregnancy received ART, and only 42% achieved viral suppression at delivery. And these differences were both statistically significant. Here we are looking at the breakdown of our outcomes by the quality of prenatal care received using the Kesner Index. Again, the yellow bars represent ART receipt. The blue bars, viral suppression, and adequacy of prenatal care is divided into adequate, intermediate, and inadequate prenatal care. And once again, inadequate prenatal care includes those who had no prenatal care. 95% of women who received adequate prenatal care received ART, and 60% achieved suppression at delivery, compared to 93% and 56% respectively when they received intermediate care, and 53% and 32% respectively when they received inadequate care. These differences, once again, were all statistically significant. Oops. There we go. All right, so the results of our adjusted analyses are broken out into two slides here. The first slide shows the demographic factors associated with receipt of antiretroviral therapy and viral suppression. Older women and Hispanic or Latinos were significantly less likely to receive antiretroviral therapy than younger women or white women. Blacks were less likely to receive ART, but this finding was not statistically significant. There were no demographic factors associated with viral suppression in our adjusted analyses. And in this slide, we show the clinical factors associated with our outcomes in adjusted analyses. Adequacy of prenatal care, timing of HIV diagnosis, and year of delivery were statistically significant in both models. Women who received inadequate care were less likely to receive antiretroviral therapy and achieve viral suppression at delivery compared to women who received adequate care. The odds ratios were 0.06 for receipt of ART and 0.3 for viral suppression. And women diagnosed with HIV during pregnancy were less likely to achieve both outcomes compared to women with a diagnosis with HIV before pregnancy. And the odds ratios are listed there. For each year that elapsed in our cohort, receipt of antiretroviral therapy and viral suppression significantly improved. So in conclusion, 85% of women received antiretroviral therapy, but only half achieved viral suppression at delivery. 25% of the women in our cohort were diagnosed with HIV during their pregnancy, and only 39% engaged adequately in prenatal care. An HIV diagnosis during pregnancy and inadequate prenatal care were strongly associated with detectable virus at delivery. And based on these findings, we believe targeted interventions for early HIV diagnosis and improved engagement in prenatal care are needed. And so certainly some of potential options of that are full implementation of opt-out HIV testing, use of social media to increase HIV testing during pregnancy, peer navigators during pregnancy and postpartum, and increased case management involvement. And certainly another finding that also probably is, to some degree has come out of our femur HIV is that integration of the HIV provider, obstetrician, and the pediatrician in the plan of care is likely to help promote increased engagement in prenatal care. Okay, so the last analysis that I will present is the HIV Care Continuum for women postpartum. There are studies that show evidence that women fall out of care and experience viral rebound after delivery, but the HIV Care Continuum for postpartum women has not been defined. We conducted a retrospective cohort study of 733 births between 2005 and 2011. The previous analyses included births that occurred in 2012 and 13. They were excluded from this analysis since we were examining 2 years of follow-up after delivery in this analysis. We looked at 5 outcomes measures that are listed here, including relinkage to care within 90 days, which we defined as evidence of a CD4 or a viral load test reported within 90 days, and I shouldn't say reported, with a draw date within 90 days of delivery. We looked at retention and care for 1 year postpartum, and we were looking for evidence of a CD4 and or a viral load test in each 6-month interval of the 12 months postpartum with 60 days between the laboratories. Viral suppression at 1 year, which we defined as a viral load less than 200 copies for the lab closest to the end of the 12 months postpartum. And we actually had similar definitions for retention and care for 2 years postpartum as 1 year, but it was we were looking for basically 4 CD4s and or viral loads over the 24-month period, and the viral suppression was also looking for a viral load less than 200 closest to the end of the 24-month period postpartum. Women with no evidence of viral loads were classified as being detectable for all analyses. Okay, so the potential barriers and facilitators to care that we investigated are quite long and are included on this slide, included demographic, clinical factors, as well as care engagement during the most recent pregnancy. So here we present the HIV Care Continuum by the year of delivery. In blue is the percent of women who relinked to care within 3 months of their delivery. And between 2007 and 11, linkage rates were fairly stable at approximately 50%. Retention in the first year after delivery increased over time, with 65% of women who delivered in 2011 being retained in care 1 year after delivery. In orange is the viral suppression rates in the first year after delivery. Once again, viral suppression the first year after delivery improved over time, with 55% of women who delivered in 2011 being suppressed in that first year. 2-year retention rates are in brown, and 2-year viral suppression rates are in green. The trend for these 2 indicators was similar to year 1 retention and viral suppression rates, with 38% of women who delivered in 2011 being retained in the second year after delivery, and 49% being virally suppressed. So HIV treatment guidelines have obviously changed over the course of our cohort, and so here we present the care continuum for both the total population and for women who had a CD4 count less than 500. Overall, 44% were relinked to care, 46% were retained 1 year after delivery, and 30% were virally suppressed. For women with a CD4 count less than 500, these numbers were significantly higher, with 51% being relinked to care within 3 months, 58% being retained in the first year after delivery, and 43% virally suppressed at 1 year. So this is a very busy summary slide of the multivariate analysis results for each of the 5 outcomes. So for relinkage to care, and I apologize, there's actually a spelling error here. It says IUD instead of IDU. I'm sure sure people can understand how that happened. But for relinkage to care, IDU as a transmission risk, a previous pregnancy while diagnosed with HIV, an HIV diagnosis less than 2 years prior to delivery, so a more recent diagnosis, and having an undetectable viral load were all associated with lower rates of linkage to care. For retention in care at year 1, we found that other race, 1 to 2 previous live births, intermediate adequacy of prenatal care, and a diagnosis of HIV during pregnancy were associated with lower rates of retention in care. Women who were relinked to care within 3 months were significantly more likely to be retained in care at 1 year postpartum. Black women were less likely to achieve viral suppression at 1 year. Women 35 years of age and older, those who got ART during pregnancy and had an undetectable viral load at the time of delivery and were retained in care at year 1 were all more likely to be virally suppressed at 1 year. And the factors associated with retention and viral suppression for retention and care and viral suppression at 2 years are also on the slide, but for the sake of time I'm going to move on. Okay, so postpartum HIV-infected women have low rates of relinkage to care, retention in care, and viral suppression. Relinkage to HIV care within 90 days postpartum was one of the most important predictors of retention in care and viral suppression postpartum. And interventions that improve care engagement during pregnancy and relinkage to HIV care within 3 months postpartum really have a major potential, I think, to improve clinical outcomes in this population. And that is the end of my presentation. And actually, do I have another minute, Erin?
Sure, if you have
I just have one, I think one additional comment, and that's the first. I want to thank all my collaborators on these analyses. They were certainly not done alone. Some folks from the Drexel School of Public Health, we actually collaborated with 2 students on these analyses, Dana Thompson and Joella Adams, and with a young new faculty member at Drexel University, Florence Montplaisir, as well as my colleague from Penn, Bali Yahia, and my health department colleagues as well.
Great. Thank you so much, Kathleen, and also to Jenny and Chad for sharing your work with us today. So this brings us to the end of our presentations, and we now have the remainder of the time to open up the line for questions. So just as a reminder, to ask a question via audio, you can press *7 to unmute yourself. Please first make sure to identify yourself and then let us know which presenter you're addressing your question to. You can press *6 to remute yourself when you're done asking your question. You can also type questions into the chat box on your screen if you'd prefer. While we're waiting for questions, I think we have one question for Kathleen. Can you talk a bit about the work that Philadelphia is doing in the community on the issue of maternal to child transmission of HIV?
Sure. So actually I was going to mention this as well. Chad would be pleased that we are one of the 11 jurisdictions that actually do allocate funds from our CDC prevention funds towards perinatal HIV prevention, and those funds actually go to 2 grantees. One is actually our case management agency, ActionAIDS in Philadelphia, who is funded to do our perinatal HIV case management for the city. And then the second is through the Health Federation of Philadelphia, who's actually the performance site, the local performance site for the Pennsylvania AIDS Education and Training Center. And so we fund a half-time perinatal HIV prevention coordinator through them. And so their job is to really be a salesperson, I guess I should say in this case, for the case management program, as well as to promote HIV testing in prenatal care settings and labor and delivery, and promote the case management program as previously described, and they also help produce, they do periodic assessments to determine what the needs are of our prenatal care providers and HIV providers as well who are seeing HIV pregnant women. And so they also are our co-facilitators for our femur HIV. So things are very, very much integrated. And so in terms of these results that I'm presenting, they actually the first question was related to, I gave a grand rounds at one of our provider sites, and I showed the data regarding the C-section rates in women with viral loads greater than 1,000. And so the question was, what's going on? What do we need to do? And that analysis really grew out of that collaboration with our grantee.
Great. Thanks, Kathleen. Do we have any questions from the audience? Okay, well, if we don't have any further questions, I guess we can wrap up for the afternoon. So if you have any further questions for NASTAD or any follow-up questions for our presenters, you can feel free to contact me. My email address is on the screen now. And again, a recording of this webinar will also be available on NASTAD's website shortly. When the webinar concludes, you'll also see a brief survey that will pop up, so please take the time to provide your comments and suggestions to help NASTAD improve our future webinars. Thanks again to all of our fantastic presenters, and hope you have a great afternoon.